Welcome class to Surgical Procedures 1, also known as 1441. Today we're going to be looking at Chapter 10 under the section classifications and focusing on cutting and dissecting instruments. I'm on page 246 in the Surgical Technology for Surgical Technologists, a Positive Care Approach, 5th edition book. So instruments that fall into the cutting and dissecting category include scalpels, scissors, and some other instrumentation that we'll go over later on in different chapters, such as bone cutting instruments, saws, drills, and so on. So, beginning with the scalpels, you might hear them called knives, and I'd like you to learn 3 components when it comes to these scalpels. You're going to always have your non-disposable scalpel handle. This is going to be reprocessed after each procedure and cleaned, sterilized, and put back into a set or peel packed so it can be used again in the future. And your second component is going to be this scalpel blade. There are different ones out there, just like there are different scalpel handles, and this is disposable. So at the end of the procedure, it's really important that it's removed from the scalpel handle and put in the appropriate sharps container. It's also considered accountable. So before and at the end of each case, and in between, there's going to be some counting done too. You're going to count these as your sharps. Alright, so the third component is this, your needle holder. This is going to help you load this very sharp blade onto the handle, okay? Now, there are different handles out there, so let's just discuss some of the ones that the book mentions and are going to be your more common ones. The first one is this number 3. There's a number 3 knife handle. There it is. Look, it comes in a longer size. 3 long. You may see this written as like a 3 capital L. But they're the same handle. One is just longer than the other. What makes them the same is this section right here. It fits certain types of disposable blades that you can take off and on here. Okay? This next item is going to be called a number 7 handle, and see how it's long and thin. It's definitely going to be longer than the number 3, but not as long as a 3L. And it's thin, like I mentioned. But what's interesting about these, even though they have different names, the top part is all the same. So the blades that'll fit on all 3 of these are your 10 blade, your 15 blade, hold these up for some comparison, and an 11 blade. So that 11 blade is very pointy. Your 15 is actually rather small, and then your 10 is a little bigger. Now, those 3 blades that I just showed you will fit on all 3 of those handles that I just showed you. So the handles were the 3 long, and 7. Your blades were the 10, 15, and 11. The next blade I'm going to show you, or scalpel handle, is this number 4. It looks pretty similar to the 3, right? To an untrained eye, these are going to look the same. But to a trained eye, you're going to realize that one is actually a lot bigger than the other. This number 4, it's wide. This top part is wider and longer. So there's actually one blade that will fit on that I'm aware of, or that we're going to learn, and that's the number 20. This 20 and the 10 to the untrained eye may look very similar, but when you have them next to each other, you realize that the 20 is much bigger. And look how the hole is a lot bigger. That's because it's going to fit on that number 4, and it won't fit on anything else. This number 4 knife handle also comes in a long. I don't have one for the lab, but it does. Real quick, let's talk about why we might want a longer handle. So let's just go back to our 3s. Why do you need 2 different lengths? Well, what are we operating on? Humans? How many humans have you seen on TV and everything that look exactly alike? Other than, you know, twins. Not very many, right? And even twins have some sort of differences most of the time, right? So think about that it's like that on the inside too. We're not cookie cutters of each other. Cookie cutter models or whatever of each other. And so as a result of that, you may need different instrumentation for the same procedure on one patient versus another patient. If you have a little old lady who comes in to have a exploratory laparotomy done, which exploratory laparotomy means they're going to make an incision from the xiphoid process down to the pubis, very large incision vertically down the midline of the abdomen. And you have a little lady who comes in who's only 90 pounds, soaking wet. The need for longer instrumentation goes down. However, if you have a, 40-year-old woman who comes in with extreme truncal obesity for genetics and then poor lifestyle and diet and stuff like that, whatever the reason is, she's got a lot of fat around her belly, it's going to make her abdomen a lot deeper when they're lying in the supine position, meaning on their back, and so they're going to need longer instruments to go past the wall of adipose tissue of fat that will be there before they even get to the abdominal whatever organs they're working on. If they're exploratory laparotomy, they may not know exactly what they're looking for, but if it's something pretty deep, they're going to need the longer instrumentation. So many instruments come in a longer version of themselves, so it's not just knife handles. So anyways, the number 4 also comes in a longer version. So that's why you would need it. Another knife handle and blade I want to discuss with you is this beaver. See how it kind of rolls around? The rest of these don't do that. They're all like really flat, right? This rolls around like a pencil. And then it's got this top here, you see that? And this can come out. Sorry, right there. See how it screws in? And what you can do is you can just screw it back in, but man, it's so important that you don't lose these because if it comes apart, there's always a chance that it can end up in the body. So keep an eye on this, all right? Don't lose it. Make sure it's on there tight enough to not become loose. There are different blades that you can use with this. The most common one's going to be a 69 blade, and what it does is it looks like this, but see how this has a weird angle? Can y'all see this? This is not a 69 blade. This is an eye blade. The 69 blade will be similar to this, but this angle will be straight up, and like this, the 69 will have a double edge sharpness to it, where most of our blades are just going to be sharp on one side. That's the sharp side. On the 69 blade, it's going to be straight and then sharp on both sides. So that goes with this. And then there's one more blade that I forgot to mention. So if you look in your book on page 247, and then you look at C, figure 10.2C, I'll see if I can put it in front of the camera here. You see this like crazy shaped one? It goes off to the side. So that's a number 12. It's not that common. If it's going to be used, it's likely it's going to be used for tonsillectomy. I've seen it used for other things, but I think that was just a special to the surgeon thing. But anyways, I don't have one of those in the lab. But if I did, it would fit on one of these 3 handles. 3 long, or the 7. And in fact, if we're using it for tonsils, I would use it on the 7 because the 7 is longer than the 3. You don't really need it to be this long, do you? That'd be pain. The longer an instrument is, the more a surgeon doesn't have control over it. Because if they're having to reach pretty deep, they're probably not going to be able to grab it very well like you would the 3. But if they're kind of trying to go deep, the longer it is, the less control they have over the end. So you really don't want to give them the longer instruments unless they really need them. If you're doing a tonsillectomy, you don't really need this long one, but it might be nice to have this thinner one, and then the surgeon can put that 12 on there and then still be able to do the tonsillectomy and be comfortable. You want your surgeon to be comfortable. They're doing some pretty serious stuff. So, all right, I did come across this though. It's called a stitch cutter or something, and it kind of looks like a number 12, but it's not. It's not going to fit on any of those blades, but see how it has that crazy angle? It's kind of like that, but this is not a 12. I just kind of wanted you to see how pronounced this angle is. All right, so when might you use these? We've already talked about the 3 long. Well, we'll talk some more in a second. All right, so your 3 is going to be your most common. Now, a lot of your initial incisions, you're going to be using either a 10 or a 15 blade on a number 3 knife handle. Now, the way you load these is you're going to use your right hand, and then you're going to kind of have your blade. You all see this? If I do this from the back, you're going to kind of have your blade pointed like out, and you're going to grab it right here. Okay. Oh, I've got the wrong one. That's a 20. You're going to do the same thing though. You can grab it right there. And then I'm going to take this, and unfortunately it's going to be hard for you to see in the picture. We'll practice this in the lab. But you'll put this on here a certain way. It's easier if you kind of have it down lower, and you need to make sure you're pointing away from yourself, because otherwise you can hurt yourself. But what I did is I put this on, and then now you can see it. We'll practice in the lab. I know it was hard to see in that video. But anyways, you'll use this for many of your incisions, the number 10 blade. You can use a 15 blade for smaller incisions, okay? That exploratory laparotomy, where you make the incision from the xiphoid process down to the pubis. I always want to say mons pubis. I guess it's the same. But you wouldn't want to use this tiny little blade, right? You'd want to use a bigger blade. Some places even use an even bigger blade, like a 20 blade. But anyways, for smaller incisions, like maybe an inguinal hernia or something on the wrist, they might just start with this 15 to make the incision. As I'm sure you learned in microbiology, our skin always has some sort of flora on it, some sort of microbe on it. We can't ever get rid of all the microbes on our skin. So when you're making a skin incision, those microbes will be on that blade. So it's really important that the blade that you use for the skin incision is not used again deeper inside the body. Get a new blade. Okay. Now, talked about the 10 blade. The 15 blade we said we'll use for smaller incisions, and also this is going to be the blade that they're probably more likely to dissect with inside the wound. Once again, if you make an incision with a 15 blade and then the surgeon wants to dissect deeper inside the wound with another 15 blade, or with the 15 blade as well, make sure you give him a new one, him or her. And it's really important that you communicate with a surgeon when you're giving them a new blade. I don't think you have to do it the first time, like when you're making the incision and the surgery's just starting, but as you go through the surgery, if you're adding a new blade, because you know they're doing dissection, say, hey, that's a new blade, before you hand it to them. Speaking of handing the instruments, these are sharp. So when you're handing them to the surgeon, kind of treat it like a pencil. Surgeon says knife or scalpel, you're going to hand it to them. And you're going to make sure that you don't stab them. Some hospitals will use something called the neutral zone, and it's this area between the surgical technologist and the surgeon and their assistant, where you wouldn't hand anything sharp directly to their hands. You'd actually set it like in a basin between you and the surgeon, and you would set that sharp instrument in the basin, and then they would pick that up, and it's called the neutral zone, where there isn't more than one person touching a sharp at a time. You're going to see this in your book. You're going to see this potentially on your boards. At our clinical sites here, we all do the old school handing it to the surgeon type thing, because that's what they expect. But you'll notice there is going to be a couple where you can tell they were trained in different parts of the country, and they do the neutral zone. So anyways, they don't necessarily say it, they just threw the blade down. So whatever, but that's the neutral zone. That's how you hand them. Let's talk about this funky 11 blade. So the sharpness is right here, and of course the point is very sharp. Now, even though this 11 blade will fit on your number 3 knife handle, your 3 long knife handle, or your 7, what I would say the most appropriate place for it is going to be your 7. And it's easy to remember because it's like 7-11, like the convenience store. And of course you will just, load your thing up, as mentioned before, like so. You've got your 7-11 scalpel. When would you use this? We've got a couple different answers for you. Anytime you're doing a laparoscopic procedure, they're going to put in these things called trocars, and you don't need a big incision for these trocars. In fact, that's part of the benefits of laparoscopic surgery. And many surgeons will use this point to make their little incisions for their trocars. I have worked with a surgeon, or actually a couple different ones, that will use the 15 blade instead of the 11. Either way's fine. Do what your surgeon wants. And but I'd say that the 11 blade is actually more common. Now, another thing you would use the 7-11 for, and really this is what sticks in my mind, is in the vascular specialty. Pretty common that you're going to have to create an arteriotomy. If you don't know what I'm saying, go look it up, because you've already had med term, you should know this by now. But you'd create an arteriotomy, so you would put your little hole in the artery, and then you would extend that arteriotomy with some special scissors that I'll show you here in a little while. So that is also another common. Why might you put this 11 on this long 3? Like, what's the purpose of that? Not that common, but yes, it does happen. Really only seen it in abdominal vascular surgery. So maybe we'll touch back on this when we get to that chapter next semester. So we've talked about the 10, the 15. Yeah. So let's move on to this 4. So remember, I did say this comes in a long. We don't have it in the lab. And then it's got the biggest blade of all of them that goes with it. It's got the biggest thing here, and it's got the biggest blade. So yes, when you get into clinical, your preceptors are going to expect you to be able to just recognize this stuff. So if you're really struggling with keeping things separate because your eye hasn't been trained to that yet, work on it. Number 4, pretty big knife. Blade. Why would you use this? Why do you need a bigger one compared to this 10 that I already talked about, right? Well, that incision that goes from that laparotomy incision, it's a very large incision. It's better to use a large blade. The 10 or the 20 are appropriate for that incision, but not a lot. It really just depends on where you are. But currently in the clinical area where you guys are going to be, they're going to be using this 20 blade a lot more, especially for your laparotomy incisions, and then they like to use it for some orthopedic incisions, such as total knee and total hip replacements. And then this beaver blade, how do you put it on there? See, I've got this really funky one that's intended for eyes, but like I said, the 69 one, which is straight like this but straight up and down, that's going to be what you're going to be more familiar with. But when you do put it on here, make sure this thing is unscrewed pretty good, and because if it's not, it makes it really hard to get on there. And then you can grab this, because the sharp part's at the end. You can grab this with your needle holders, and then you're going to have to very carefully put this in here. I'm trying to do it where you guys can see it, but that's really not safe. You're really supposed to keep it, you know, down here. So I just really don't know if I can show you with my limited space here, but and these are old, so it's a little harder to get it in. There we go. So there's like this little slit that you're supposed to get in there, and you will cinch it down until you can't cinch it down anymore. And then what you can do is you can hold this thing that you just cinched that into, and then you'll turn this until it's nice and snug, and then you got yourself a loaded beaver handle. Don't forget that blades are countable, so you'll count those at the end and at the beginning of each procedure and in between as well. But I think that's it for right now on your scalpels. So I think we can move on to scissors. Scissors. Let's start with our basics. So there are so many scissors out there. There really are. Scissors have to be sharpened. There is a special person out there that is specially trained to sharpen surgical instruments. Scissors aren't the only thing that need to be sharpened, but as you know, even with your scissors at home, they get dull, right? Well, we can sharpen our scissors here. Well, not here, but you know, there's somebody who comes and sharpens anything that we need sharpened. So that's great. So let's start to talk about our basics. Let's first look at our Mayo scissors. Not Mayo like mustard, but Mayo like Dr. Mayo. You'll realize a lot of equipment and instrumentation are named after surgeons who more than likely created and invented the equipment and instruments, so Dr. Mayo. But you have your straight Mayos and your curved Mayos. Okay, most of your surgical instrumentation are going to have this little curve here, all right? But for the Mayos, we have our straight and our curved, okay? Let's talk about the straight. So straight Mayos, you may more commonly hear these referred to as suture scissors. You need to know both names. And suture scissors are not intended for dissecting tissue. Suture scissors, straight Mayos, are intended to cut things that aren't tissue. So suture, such as what they're named after. Suture is that string that they use to approximate or close the wound together. There's got to be something that you use to hold it. So that's what suture is. You would cut suture with it. You can use this to cut mesh that they might need to leave inside the body. You can use it to cut drains because it's kind of a thick plastic. And so because of the heavy material that you use, that you are allowed to use these on, these would never be appropriate for tissue. With that being said, your curved Mayos and any other dissecting scissor that you would use on human tissue, you should not use to cut any non-tissue things with. So you would never use this to cut suture. You would never use this to cut mesh or drain. Only use your straight scissors because you don't want to dull these, right? It costs money to have these things sharpened. So these are your two scissors. Now, I'm going to set these down. These are so common. They're going to be in all your sets. You're going to have it on your Mayo all the time. These are your new best friend. All right, let's bring up the Mets. So now I've got my curved Mayos, and I've got my Metz and Bombs scissors. You may hear these referred to as Metz for short. And these are thin. Here, let's have them facing the same way. These are pretty thin compared to the curved Mayos. These Metz and Bomb scissors are really common. They're gonna be in almost all your sets. You're gonna use them from almost every surgery. And these are your classic, it looks like someone's cut glue with this, but these are your classic dissecting scissors, and they're thin. They're great for medium to kind of delicate dissecting. They're smaller scissors for more delicate procedures. But you don't want to use these on heavier tissue because, number one, it can't handle it. They're really thin. They're lightweight. When you get to the lab, just kind of hold them and compare them to other scissors. And they're lightweight. If you try to cut thicker tissue with this, it's just not going to work, and you could end up damaging them. So if you're working around thicker tissue, you might use these curved Mayos. Like I said, these can pretty much be used for most cases. However, like if you're doing a hysterectomy and you're working on removing the uterus, all the tissue that holds that uterus in place is pretty thick, and you would need a heavier scissor for that. But you really wouldn't need it for like more delicate stuff. So once again, let's start to use our common sense and think, okay, we're working with denser tissue today. I might need to know where these are. We're just doing regular old hernia stuff. Maybe I can use these. You're going to use this is going to be in every single one of your setups. We'll teach you setups, and you're always going to have both of these available. All right, so suture, straight Mayos, curved Mayos for heavier tissue, Mets and bombs, also known as Mets, for medium to delicate tissue. These are going to be scissors that you're going to have on a lot of your Mayo setups. A Mayo, which you will learn soon, is a little table, I guess, that we use to put all of our very important instrumentation on. We keep it in front of us so that we can hand things to the surgeon and have everything ready instead of having to go to our back table all the time and turning our back to the sterile field. We want to do that as the least amount as possible. All right, moving on. So there's so many other scissors. We'll just focus on a few more. Let's look at these. Now, at first glance, you may think these are just more Mets. They're very similar at first, but when you really start to looking at them, they're not. These are thinner, and these, the tips are different. It kind of goes in, it tapers in a little bit on these tips. These are called tenotomy scissors. Because of the delicate nature and pointiness of the end of the tips, you're really only going to use these for more delicate surgeries, maybe a wrist in orthopedics or something like that. It doesn't have to be orthopedics though, it can be a lot of different things. So let's just stick with delicate surgery for now. So that tip was really small, right? There's these, which are really short and tiny. They're a little bit longer than the palm of my hand. I wear like a 6 glove, so that kind of gives you an idea. I'm sure you guys will figure out what gloves you wear. We'll work on that. But anyway, so here's your Mets, which was pretty delicate, but look at this iris scissor compared to it. They're a lot shorter. The tip is not tapered. Oh, can you see? The tip is not tapered like it is on the Mets. So there's another thing. But yes, iris scissors. They're very small. Once again, delicate surgery. And we can even get smaller. I mean, they even have micro instrumentation. There's Westcotts. There's these, I have these fun, forgot what they were. I have these fun Castro Viejo micro scissors. There you go. All right, and so they're really small. And there is one more thing I wanted to check on here. That's all right. Anyways, micro scissors. So another delicate surgery scissor might be this pot scissor. These come in all different kinds of angles. This is more of a peripheral vascular instrument, so we'll worry about that next semester more, but I do want you to go ahead and learn these this semester. But see that angle? Like I said, they come in different angles, but remember how we were talking about the 11 blade? 7-11? 11 blade on the 7 handle? An arteriotomy would need to be made with this little pokey part. And then what they would use, they'd make the arteriotomy, and then they'd use this to extend that arteriotomy. So that's what these are for. Getting away from more delicate surgery, let's move to these funny things. These are very large. The longest ones I think I've shown you today. Let's compare them to our suture scissors. See, they're pretty long. And the main thing about this is this very pronounced curve, right? These are called Jorgensen scissors, and they are used, I consider them gynecology scissors, because for an abdominal hysterectomy, it's not super uncommon for when it's time to remove the uterus and you're at the very last place where it's still attached. The surgeon may put these down into the abdomen. So that's why they have to be long, because they're going down and they're actually going to pull up the uterus, and then where the uterus and the vagina meet, they're going to cut in that area. Sometimes they leave the cervix, sometimes they don't, and they remove the uterus, and this curve is because they're going deep into the abdomen. And then, I wish I had something drawn, but think of like vagina, uterus, okay, and then there's that little area where they meet. And they would have to kind of go in this curve, like helps to, you know, just get that one area that they need to cut across. Now anyways, Jorgensen's. Got all those. Here's a couple more. So I've got these two scissors. They're both like kind of funky angled. This little one, can y'all see how there's like this little hole in there? You'll see these holes. See that? Those little notches? These are wire cutting scissors. Don't use anything else to cut wire with other than these, otherwise you're going to damage your scissors. These are Lister, Lister scissors, or Bandage scissors. So they have this thing right here. It's kind of like a guard, like a protector, and you can cut off bandages with it. And it's not going to be pointy like other scissors are. Non-bandage scissors, and you're less likely to cause damage to the patient or other things. So I think that's it on the scissors. And the scalpels, like I said, those other instruments like bone cutting instruments and whatnot will be covered in a later chapter. So I think that's it for now. See you around.